Okay, good morning, everybody. This is the lecture between the years. It's about tips and tricks in body imaging procedures to get you to that rotation, and a few of you have been already through that. Some have not. So we're going to talk a little bit about, let's see if the slides move forward or not. They don't. Maybe the keyboard is not completely on top of things. Try the mouse. Okay, just going to click on it. Sorry about that. Okay, we're going to start a little bit with a famous quote. Who of you has read this book here, House of God? Have you read that? Okay, that's kind of the mantra of some of us. So it's about getting to any lesion that we need to. Yes, there's limits. We're going to talk about those limitations in some way too, but the overall attitude should be, yes, we can do it, right? So there's a demand for a lesion, and our colleagues need some tissue. We try to get to that. All right, we're going to talk about different things in general first, about local and non-local anesthesia, technical approaches, the armamentarium we have, the biopsy devices, some techniques in ultrasound, and some techniques in CT. And that's pretty much it. The most important thing is to have a plan when you see a lesion on a modality. If it's CT, MR, PET, or ultrasound, you have to plan the approach. And to do that, you also have to check if the indication is right, because sometimes the approach is so tricky or dangerous, it might not be worth it, or it's really not worth the risk at least, right? You have to take a look into what the patient is overall like. The patient is frail or in good shape, can the patient hold his or her breath or not? Take a look at the coags, and then decide on the anesthesia, if it's local, moderate, minimal, or general anesthesia. And it also depends on the skill level of the operator or operators, and also on what armamentarium you actually have available, and if you have rooms in CT or ultrasound, if there's any logistical shortcomings. By the way, if you want to crank up the lights a little bit in the background, that's totally okay, right? So you don't completely get challenged with the darkness here. All right, usually in the literature, there's these two parameters that we have to keep in mind. So if the INR is 1.5 or lower, it's okay to do. 1.6 is considered a little too high for full core biopsies, and platelets should be 50K at least. Things are a little different for FNAs. We're using up to 3 now for FNAs for INR, and go down to 30K for the platelets. That is all kind of a relative ramification, right? So keep in mind what the target is. If you have a compressible target, let's say subcutaneous mass, and the coags are really bad, you can probably get still by with worse values than these because it's compressible. That's always important. If you have a lung biopsy patient, there's no way to compress, right? Once you click, then you have a bleeding source, and there's no way for you to put in any gel foam or anything. The lung is just going to bleed. And your ultimate resort would be help from IR with coronal embolization or bats or something like that, but then things can spiral down quickly. So make sure you got all your logistics in place. So let's show you a few examples, and if the indication is right, okay? So obviously this is a body imaging lecture, and this is above the clavicle, so it's starting to get challenging for us. But the demand was to biopsy this target here, right? It's a contrast enhanced CT. Obviously there's contrast enhancement in there, and this is sagittal MIP, as you can see, so it's a submandibular node. On a patient that I don't know anymore exactly what the circumstances were. And on MRT1, it looks like this without contrast. It's a mildly indeterminate, intermediate intensity lesion here. And then with contrast, it kind of fills in, right? Or shows enhancement. On ultrasound, because we were to do that with ultrasound and Doppler, you can see it would be hypoechoic and some flow in the periphery of that or adjacent to that. It was kind of hard to say. And it's pretty low scale already. So remember, the lower the scale, the slower flow you're going to pick up, right? If the scale is too low, you're going to end up with artifacts too. So you have to kind of titrate finely how to get to the ideal scale. And with B mode, which is officially the better grayscale quality, it looks like that. So it's not completely hypoechoic like a cyst or a fluid kind of thing you would be, but it could be because you're also dealing with reverb artifacts because you are dealing with a lesion in a near field, right? So it's about a centimeter distance from the skin. So putting color on with a lower scale now showed us some surprise, right? So now the scale is really, really low, right? Just 1, even low already. And now you do see a lot of flow. And that's not only artifacts, because yes, the straight line could be an artifact, but this one here is no longer an artifact. There's actually like kind of a swirl within that lesion. As you go back to the MR and look closely, you could see like a yin-yang sign on the corona. acquisitions here which you did not see on the sagittal ones, at least on the ones with contrast. And this is a non-con T1 that shows you that flow can be hyperintense on T1. So it's important to realize that was not picked up basically in the report. If you see flow in T1, that means that lesion is not enhancing, it's just a part of the blood pool, right? And that ended up being basically a varix of a vein which you don't want to biopsy, because you end up with some bleeding. Even though it's a pretty superficial thing to do, you still don't want to biopsy because there's just no indication to biopsy, right? All right, so just look at everything you have, look at all the sequences that you have available. Despite the reports, you may pick up things that may not have been picked up before. It's pretty rare, but it could happen. And ultimately, because you are the one who's going to stick a needle in there or are part of it, part of the team, take a look at the images yourself or scan yourself and play with the settings. Don't rely on others if you have any doubt. Mostly, yes, you can rely, of course, it's all a good team, but you are the one who's ultimately responsible, right? Okay. Then you have to decide in what kind of anesthetic setting you have to do everything. Depends on the organ. If it's an organ in the peritoneal cavity, then you probably need some sedation or a very good local anesthetic at least. But remember that the visceral organs have their own peritoneal air, so there has to be anesthetized as well. It's not good enough to just numb up the abdominal wall. You have to numb up also the visceral surface of the organ, particularly the liver, if possible. And you have to decide on what approach you're going to do without going through bowel if you don't need to. You can, but not with all gauge size needles, obviously. You have to keep in mind how long the procedure is going to take and also what the patient would like. So that's a more and more important factor nowadays, where patients have more and more to say what they want, which is totally okay, but we have to be considerate of that. Particularly at Harborview, many patients want conscious sedation or general anesthesia because there's different emotional circumstances, right? And it depends a little bit on what the workflow is and what the culture of the institution is. If you go to other countries, you rarely do conscious sedation, to be honest, in peritoneal procedures like liver biopsies. That's more the exception than the rule, but here's the opposite. Here you do mostly moderate or conscious sedation for peritoneal procedures, just so you know. Okay, it's important to have a routine when you set up your procedures, because a routine can help you, number one, to not forget things that are important, number two, to be more efficient, number three, also to help the patient. I'll tell you in a minute why. So this is a four-step workflow that helps the patient because it takes advantage of the fact that local anesthetics take some time to kick in, okay? So every second almost counts with lidocaine and the buffer. And if you don't take advantage of that, just because you want to be efficient, the patient's going to have pain, and you don't want that. It would be unfair, right? It's not an intentional thing, but it's often people are not aware of that. So you start with the skin prep, provided that you have your table set up, all the instruments are on board. You don't need to have the biopsy devices open because these are the most expensive part. You leave that for the end before you're ready to really go in, because things can change, right? Patients can have a complication with anesthesia, or they change their mind, or they move around. You see, it's just not going to work. So you don't want to open the biopsy device before you're totally sure that you're really going to do the biopsy. So wait until you have even done the local anesthetic with that. So step number one should be just prep the skin, clean the skin, because time also works in the patient's favor. So while, let's say, the ChloraPrep is kind of air drying, it acts, right? So it kills bugs. That time you don't need to wait, you just do other things. So in the meantime, you draw the local anesthetic. And nowadays, there's a national shortage of bicarb, as you know. However, Harborview has started again to receive bicarb. That's good. So now we have bicarb at Harborview, but we don't have it here at the U. Don't ask me why, I don't know. But the fact that you don't have bicarb means that it stings much more. That means for you and the patient that you have to inject much, much more slowly. Otherwise, it's going to burn like crazy. Right? So the patients really suffer from not having bicarb within lidocaine. So then you inject the local slowly, and while you do that, you let it sit there and act. You don't wait. That's the time where you're going to start to open your biopsy device. The sample containers get ready and all that kind of stuff. So these are our precious seconds and maybe a minute or two to get it all ready. Test the device if it's working, if it's the right size, if the introducer fits nicely around the biopsy device and vice versa, and then you're ready to go. And the usual perception is that if you do like a very flat approach into the dermal layers, you're going to do the patient a favor, which is mostly or sometimes okay, but still you're going to see patients who have a lot of pain when you do this approach, because many people just go in there too deeply. So what you don't want to do is go in a centimeter and a half and then inject, because you're going to go through non-numbed up tissue, right? The better way to do is just to inject even when you're outside the skin, so you see some fluid spilling around, and then keep injecting as you go through the dermis. What I prefer more is this one here. So remember, a mosquito doesn't sting much, but it does to some degree. And one of the reasons could be that it's just a very superficial injection or sting. The other reason is that it goes in perpendicular. So if you're a mosquito, go in really perpendicular to the skin and start injecting right away. The reason is that the tip of the needle has a certain bevel, and that bevel obviously is not always facing the skin when you do this one here. If it does, even better, but be aware of that you really face the opening towards the skin, so you're injecting lidocaine immediately once you're in there. But if you don't pay attention to that, this approach can also be helpful and cause less pain. Remember again, to inject immediately, you don't need to aspirate. But once you go deeper beyond the dermis, then you want to follow a very stubborn approach, which is aspirate, inject, and advance. Okay? Aspirate, once you see blood, don't inject, just go a little deeper or pull back. Okay? Then you inject, so you create a little lidocaine pad, which is like the numbed up portion, and then you go through this numbed up portion. Right? Don't go in first and then inject, because you're gonna go into non-anesthetic areas, right? So you're gonna go through sensitive portions. Okay, let's get a little serious now and look at a few pictures and targets, because now we're gonna see how we're gonna numb up if we go on our way to the target. So that's the liver. Should be, there's a few mets in here, or target lesions. So target lesions are first, so we call it target, whatever we're gonna biopsy, we call it target, right? But within ultrasound, you have a so-called target appearance. That's a different thing, right? And the target appearance is a concentric, well-defined lesion which has like a hypoechoic halo in the periphery mostly. That's classic for a met, right? This patient obviously has mets, but they were to be biopsied. And this echogenic line here is the interface between the peritoneum and the liver. And with color, you first make sure there's no major blood vessels in your way. And this dotted line here should represent the biopsy trajectory. And you're gonna make sure particularly that the gastrics are not there. Often bleeding happens not within the peritoneal cavity, but in the subcutaneous layers or in the muscles, right? And that's usually either due to muscle branches or due to the epigastric veins and arteries. So here you determine the length of the biopsy path that you need to pick, and depending on this length here, you're going to select the length of your biopsy device. And now we're going to do the local numbing. The local numbing goes through muscle in here, goes to peritoneal layers, and goes into the capsule if possible. You can't always do that because people are moving around and that kind of stuff, and some people don't feel comfortable going to the liver capsule. But if you numb up a little bit portion of the capsule here, that's already very good, because the patient's going to ultimately have less pain, provided that you go through the same spot with the biopsy needle. That's the key thing, right? So sometimes it happens that things move around, particularly with moderate sedation, and the diaphragm is more relaxed than before, and then the patient doesn't breathe in the same way he did or she did with local anesthesia only, right? So make sure you're really going through the anesthetized portion. Particularly important for so-called low-key procedures like paracentesis and thorax. So here's a para patient, and as you know, unfortunately, many of these patients are end-of-life or term patients or chronic patients, and they are very cachectic, and that means that you have not too much tissue to go through. So it's like this patient has just less than half a centimeter of perpendicular distance from the skin to the peritoneum. It doesn't give you much space to properly anesthetize the patient. So you want to go in a very tangential pathway, because if you go in straight, you also increase the risk for a leak. A leak means that if your patient has still residual ascites after the procedure, because you may not always be able to drain the complete fluid for different reasons, and you have still intraparenchymal or intra-abdominal pressure that kind of pushes the fluid out, and a paracentesis-related ascites leak is a nasty thing to have. So here we basically determined there was, like the old days, the skin to peritoneal distance and then the skin to mid-pocket distance if patients were to be done on the floor by the clinical teams. They don't do it in real time ultrasound, but we mark the skin, and then the team sees this picture and then go straight in there. So they go like half a centimeter max for sub-Q anesthetics, and then they go in, like in this case, almost 3 centimeters to place the catheter. If you do with real-time guidance, you want to go in tangentially. So again, you take color, make sure there's no flow in there or there's no major blood vessels in there. And then you create the lidocaine pad, as we call it. So you really want to see that there's a lidocaine deposit in the air where you're going to go through with the catheter. And then you also want to stretch out the distal layer of the peritoneum. So you want to actually ideally thin out this echogenic line. Then you go in there with your catheter. In the meantime, the lidocaine here has already heated. This image wasn't taken immediately afterwards, but while the fluid was running. So lidocaine dissipates pretty quickly, just so you know. So create a little pad. Don't wait forever. Go to the pad, the lido pad, because it's the best cushion for the patient. And then after the para, which means like the fluid is gone, you still, if you sweep around, you're gonna still see the lido pad here and there. So this image before wasn't completely taken in line, but here the lido pad can persist in some areas more than in others. Mouse is blocking, sorry. All right, so before we completely leave this patient, what I'm going to show here, the lido pad has another advantage, and that is the original patient's subacute depth or was like 5 millimeters, like this one here, right? Once you insert lidocaine, you're going to increase this distance here from the skin, which gives you more leeway to do what we call the Z-track approach, which is like you don't go in straight in, but you're trying to artificially lengthen the trajectory. That helps you to minimize the risk for a fluid leak. So you're going like this, and then you angle your catheter this way and then this way, or just one angle is also good enough. It's better than no angle to just artificially increase your trajectory. Another technique is what we call the skin shift. Skin shift means you can go in straight, like in a flat angle, but pull the skin. That means once you release the skin, there's going to be some shear forces pulling the skin back together and causing a virtual Z-track technique, so to speak. Okay? That's important, again, mainly for skinny patients. Okay, so let's say we have a target that we have to approach, and we have to keep in mind, again, these things. One of them, we talked about the risk for bleeding. We talked about that there's different organs to go through, but what we have not talked about yet is the risk for bleeding and cell seeding in relation to the location of the target, okay? So let's talk about this in a minute, and let's see how we can artificially increase a short distance to the target if there's a risk for bleeding or seeding on a lesion that's in a subcapsular or subperitoneal location, okay? So we have basically two major differences in devices because they can help us a lot in doing lesions that we cannot do with the other device. Let's say one is the fine needle aspiration technique, which is like the smaller damage of the two procedure types that we have, and we have the core needle technique, which is like larger gauge lesions, devices, I'm sorry. And usually we do FNAs on patients when we have to inject something. We don't do many injections in body imaging. They are sometimes done with other sections like neuro or IR, when we do a pain treatment, right? Or we do fine needle aspirations with modified techniques with the thyroid. We no longer use the vacuum needle, but that's something that you have to keep in mind, that there's devices out there that can combine FNA technique with a vacuum aspiration technique. So it's different handles, so to speak. I'm not going to talk about these ones here too much. I'm going to talk a lot more about the two fundamental techniques that we have for core needle devices. One is a true cut side launch needle, and the other one is a full core biopsy. I'm going to show you in a few seconds here. So this is the most classic traditional true cut full core needle device. That's a device that is being offered by many vendors, and they all have one thing in common. So you have an inner stylet which you push out. An inner stylet has a trough, and this trough is basically your receiving end for the tissue. And once you click, meaning once you fire the device, you deploy another cylinder that kind of runs around that kind of trough and separates basically a string of tissue into this trough. And you have this distal block of steel here, which holds the device or holds the sample in place when you pull the needle out. It doesn't help you to cut it one way if you don't have anything to keep it secure in the cylinder, right? So that's the principle of this device. You have a full cylinder running across that trough, enclosing the sample, and you can remove the needle. So you have this kind of device, and maybe 80% of the procedures is what most people are going to use. However, more and more, there's other devices out there, and we prefer this one here much more if it's safe to use. That's a full core needle device. It has several advantages, but it has some disadvantages too. So that's a full core needle. That means the whole diameter of the cylinder is tissue. There is no such thing like a trough, which is like partly replaced by the steel that holds it in place. But here the whole thing fast forwards into the tissue because the tip itself is a sharp tip that cuts and eats its way through the tissue. Now, how are you going to hold the cylinder of tissue within the device without it being stuck at the host tissue and being left in there? There's another blade running on the outer surface of that full core device, and within one click, the first thing that happens is that this kind of whole device runs into the patient, and at the same time, without you noticing, this little blade was going to run through that notch here, and there's a little notch here, and it's going to snip off the tissue and going to hold it securely in place. However, this device portion here is very flimsy. And often enough, you will have basically a dry sample just because of the fact that this kind of blade will not run into this little notch here. And that happens when the introducer is dry. That means once the introducer is in the target and you remove the inner stylet, the moment you remove the inner stylet, you're going to suck up blood into the introducer, which is your lubricant, which is what you want. So in that case, mostly works out okay. But if you have a pretty dry target for whatever reason, let's say a lung, for example, right? You may sometimes end up not having tissue because this mechanism here doesn't work. Maybe the blade just gets stuck outside or it just runs across that kind of slit and ends up in here. You don't know exactly because it's so small you hardly see it, okay? So I'm not using this one, for example, for lungs also because it's too large. Too large meaning that I'll talk about literature in a minute. That 16 gauge, 18 gauge are high risk biopsy devices for lungs compared to 20 gauge. So there's a risk of pneumothorax and bleeding independence of size of the target, of the device, sorry. But this is a very nice device for full core solid organ biopsy. It's pretty safe and mostly works most of the time, obviously. Mouse. All right. What they both have in common, if you compare them side by side, is that the distal 5 millimeters have no tissue. That's important to keep in mind. So with small targets, let's say you have a 1 centimeter target, and this target is sitting on top of a artery or vein, which you don't want to fire through, you end up having 50% of dead space at the end of the biopsy tip, right? And only the other 5 millimeters are going to be core tissue of the target. That's important to notice. So both devices at the very distal end, the distal 5 millimeters, don't carry any tissue, but they traumatize the patient. That's important to keep in mind. Okay, so for large targets, no big deal, because you have enough tissue in here. But for small targets, you have to keep that thing in mind. But you usually want to fire through the target. Let's say a small met in the liver, you can fire through if there's nothing at risk behind that target. But if it's sitting right on top of the portal vein, for example, or an artery or bile duct, more importantly, you don't want to fire through that. Okay. Okay, so what does the ideal sample look like? This is one, it's a basically a stylish sample. It's just an oval thing, and this is our simplified introducer. The side notch biopsy device goes in there. Then you fire, deploy, and you can deploy either into the middle of the target if it's a small one, for example, and a non-safe one to go. But if you have a safe big target, you can fire through the whole lesion and get tissue, reference tissue from the distal part, from the lesion, and from the proximal part of the organ. You only need reference tissue of one piece of this one part of the side. Many targets are necrotic, like this one here, and then you definitely want to go through as much target tissue as you can because you got to carry only some target tissue in here and there. Otherwise, you're going to have just this piece here, and you never know exactly how much necrosis you're going to hit. For that purpose, it's good to go through both sides, so meaning to the full thickness of the target. If you cannot do that, consider this approach. Go through a tangential approach, so that eats through more tissue that you like, without necessarily hitting necrotic tissue. So it depends a lot on what the target looks like. With the Kolokythas enhanced study, MR, CT, or ultrasound, you can often determine where the necrotic portion is and where you can avoid that. What you don't want to have is 3-4 cores of nice tissue and you end up having it all necrotic. That happens quite a bit with large tumors. So you have to be considerate of that fact. Okay, so here's an example. Okay, what a biopsy should look like. This patient has a liver in here with several target lesions here. These are tricky targets because they show what we call the inverse halo sign. The inverse halo sign means you have an echogenic rim rather than a hypoechoic rim. And what is it typical for? Well, it's typical actually for hemangiomas, right? But mostly for larger hemangiomas, like 2 centimeters or larger, that's considered large. But you can have obviously mets that do the same thing too. Nevertheless, that's the target, this one here. And you biopsy basically from here to there, all the way to the target. So the distal tip, remember distal 5 millimeters would be in here. You may just carry a little bit of organ tissue rather than target tissue, but part of it would be also just the biopsy device with no tissue. Then you carry some tissue from here, and then you get some tissue from the proximal end. The sample would look like that. So distal to the target gives some reference tissue, which is like liver in this case. So liver is usually red or brown, as you know. Target tissue is mostly white because most targets are malignant tumors. Malignant tumors, with one exception, are usually white. The exception is melanoma. But many melanomas are white as well. Just keep that in mind. So if you have black tissue, that would be proof that you already got it very well. If you have white tissue, it's also pretty good. But what you don't know with white tissue is if it's necrotic or not. Okay. Sometimes necrotic tissue is really ash gray or brownish gray or kind of, almost black, but mostly it's white. But keep in mind that you want to have always 2 colors at least, so that makes sure that you've got in the target. Another thing, sometimes you're not sure if you're at the target or not because the target is too small. Let's say it's just a 5 mm met, and you're not sure if the moment you clicked, the patient was breathing a little bit or not. So always inspect the target carefully. It's hugely magnified. This is basically a towel, like one of those sterile towels, so you can see all the wool in here, right? So make sure you really look at it closely. Okay? And don't stop before you don't get 2 pieces of color. That's really important for the liver. Okay? It's a little different for other things, but always keep in mind you want to have some kind of fraction of white tissue, and white is not really white. It could be yellowish, it could be a light pink, that kind of stuff. But you don't want to have the color of the target organ only, right? So here's another example. A patient with a huge lung mass and obviously adenopathy around here. It's no question that this is malignant, but you want to know what it is. And this is a lesion where you can do ultrasound guidance even though it's a lung target, right? So once the target is large enough to abut the pleura and you don't have any aerated lung, you're going to be able to see that with ultrasound. And here it is. So it looks like a liver biopsy almost, right? You have solid tissue throughout. With ultrasound, very easy to see. And you can go straight in without causing any high risk for pneumo or bleeding than it would be with a liver biopsy. However, with smaller lung lesions, you have another challenge. So small lung lesions, if they are subpleural, they abut the pleura only to a very small degree, right? So the lesion is much larger than the contact zone would be. So in ultrasound, if you would ultrasound, you would expect much more to see than just this portion here. And in this case, you could do it with ultrasound. So why would I do it with ultrasound? Why don't you want to do it with CT? Well, with ultrasound, you have the huge advantage of real time, right? Remember, with CT, you only have the patient take a breath in, you scan, breathe out. While you scan, you cannot bring the needle in, right? Because it's in the scanning plane. Your hand is in there, or some holding device, or something, right? So you want to just scan incrementally, even though we have the step and shoot technique or the fluor technique. It's not the same as real time. So you try want to do anything you can to do a lesion with ultrasound guidance. And this technique, which is actually published, is actually pretty nice. It's ideally done with the side notch technique where you have a thinner trauma through the pleura here. If this would be the pleura here, this one there, right? You can navigate the lesion, the device into the lesion with minimizing the trauma. And then you fire into the lesion with the trough secured in the target beforehand. Here's an example. This lesion is difficult to get to. Obviously, you have the scapula here, you have ribs, and it's in the lower lobe. So the lower lobe is notoriously difficult because of breathing motion, right? So the upper lobes don't move as much as the lower lobes do. So whenever you see lower lobes, you kind of start to get a little anxious and have to really plan the approach carefully. And then if the lesion is small, it doesn't matter, but if it's abutting the pleura, that's what matters much more, right? So if it abuts the pleura, there's always a potential to get to that with ultrasound. And this patient wasn't good in hearing either, so holding her breath in CT is basically almost impossible. So you have to do it yourself with free breathing. And this is what you do. You place the patient on her tummy. So that moves the ribs around a little bit. You get the arms up or down. You do anything you can to get that lesion exposed to the pleura with no ribs above. With ultrasound, it looks like this. So first one, you don't see anything, right? This is like the chest wall here. This is the pleura. And then you see this little cavity here, this kind of notch. And that's a target. And there's lung around it, so you don't have much space. So from dot to dot, here's 1.3 centimeters with this vendor. It's not 1 centimeter, just so you keep that in mind. So it's less than 1 centimeter throw length, but it works. So here's the part of the lumbar needle coming in. Here's a renal introducer. You get as close as you can to the pleura, and you try to get real-time window where you seal the target. Here you don't see it, but here you see it. So breathing is important. Then you fire the needle into the target. So it's a difficult procedure, but it can be done, and that's the only option you have with patients who are hard in hearing and can hold their breath. This one worked and ended up being adeno-CA. Okay, with ultrasound, it's important to know your tools, right? That's why we always insist on you guys trying to, after you learn the whole anatomy and pathology, to learn how to scan, at least to some degree. You know what all these gizmos here mean, not all of them, but at least the most important ones. For example, C stands for compression in some vendors. Compression is like the window in CT, right? The higher this number, the more grayscale values you're going to have in there, which means the more milky the image is going to be. If you bring the compression down, which means like a narrow window, you're going to have a more crispy image, but it's also going to be more noisy. That's important to know. You have to try to identify a flimsy needle within a noisy image, okay, just so you know that. And frequency and focus, of course, you all know that already. Okay, here's also another thing that you have to keep in mind. So that's an ultrasound of a right thyroid lobe. This would be the trachea. That's the right lobe, transverse shot. This is the carotid artery, and here's a needle. Very easy to see, right? It's a pretty flat angle. You can see a lot of reverb artifacts with flat angles, which is good because it gives you an easier time to identify the needle. How about this one here? This one is also the right carotid lobe. Trachea is in here. Large target, and here's a needle. Same size needle, but much weaker. So you don't see it as well. Why not? The difference is the angle, right? So the angle in relation to the insonation angle has to be as flat as possible in order to give you a good reflection. So the other way around, the steeper the angle, the tougher it is to see the needle. Just keep that in mind. So if you have a hard time seeing the needle, try to find a trajectory which gives you a more flatter approach if possible. Gives you an easier time. Okay, another trick to identify the tip of the needle is to inject air. Okay, so we do this sometimes if we don't see the tip of the needle well enough. It's not good. It's better to use this air injection technique to verify the nature of a target. So sometimes you cannot tell if a target is solid or liquid. And they're going to ask you to aspirate an abscess, and then you're going to find out why you can't. This patient here, for example, has acute pancreatitis with different pockets. This one was surrounded by a bowel. This one here was a little tricky too. So we ended up going after this one here. Here's a needle, but you couldn't aspirate anything. There was nothing that would come out, even though it looks very liquidy, right? And then you inject and you see that the fluid, the air bubbles don't float all the way to the top. It means the fluid is stuck in a semi-solid matter. You see that, then you can pretty much predict there's nothing to aspirate. It's all coagulated blood. You cannot say that just based on the CT image alone or based on the ultrasound image alone. It all looks very hypoechoic or hypodense. But this little trick that sometimes helps to prove that the target area is not liquid enough to be aspirated. Okay? In this case, you can either fire a full core, which you usually don't do, or you just do nothing and tell that it's coagulated blood. Okay? But pus, you should be able to aspirate. Of course, keeping in mind that if you use a too small needle, then this test will fail, right? So for aspirating an abscess, you want to use at least 20 gauge to have a large enough introducer or needle to aspirate the thick fluid. Okay, there's a few more cool devices out there that can help you to get by. That's the famous Hawkins needle, which IR has. We borrow it sometimes if we need it. At least they used to have it. And that means that the introducer of the needle is not sharp, like normally it is, but it's blunt. And that means that you can go through organs or next to organs without traumatizing them. They basically would kind of slide away. Okay. So here's an example from literature. This patient here has a perisplenic nodule. And it's kind of difficult and risky to navigate through that. Usually people don't want to go through screening, though you can do that. There's publications on the safety of doing transsplenic or splenic biopsies too, but let's say you don't want to go through screening for whatever reason, which is totally okay. You can use a device like the Hawkins needle with a pretty blunt inner stylet, and once you are sharply through the difficult portions here where you cannot go through with the blunt tip, obviously then you switch to the blunt tip, and then you can move the blunt needle forward to the target until you're here, and then you can basically securely, safely biopsy the target. You can also do that just by going through a bowel, and it's going to be gently be pushed away. Keep in mind, though, this does not work if you have adhesions, right? Because there's no way that you can take advantage of the sliding nature of bowel because it's all stuck. So in this case, it's not going to help you much. So always keep everything in mind in terms of what the patient has been through already and what not. Another big no-go is to go straight through a potentially malignant target if it's not surrounded by host tissue. At least not in the peritoneum. That's different for the retroperitoneum. Retroperitoneum is not a cavity. Everything is going to be contained. So if you cause seeding, let's say around a perinephric mass, the cells are going to stay in place, and you can still ablate them later on in second stage, for example. But if you cause seeding in the peritoneal cavity, you not only upstage the patient, let's say it's an HCC because it wasn't outside the liver before, but you can make the patient's life miserable by causing malignant ascites, and we've seen that too, right? So be sure you don't do that. That's obviously a CT image from an outside facility, of course. Don't do that, but you try to, this is what can happen, right? So this is a post-procedure complication published in Tom Winter's paper a few years back, which is an HCC that has spilled into the whole peritoneal cavity, right? This is like the nightmare of every biopsy guy, right? Or person. You don't want to do that. So this can happen if you do that. It can always happen theoretically, but you want to minimize the risk this way. Okay. So don't do a direct approach if you have a subcapsular lesion, as long as you can avoid it. It's a little different with metastases because it's already M1 staging. However, still keep in mind, if you have peritoneal metastases, the patient's life quality is going to go miserable if you have ascites. It may not be, but could be. So just keep that in mind. Here's another example where you have a almost pedunculated lesion. That's the left hepatic lobe with ultrasound transverse image. Here it is. So that's also the outside CT guided procedure. We would do it with ultrasound guidance, obviously. And for some reason, they went straight to the target. In this case, it went okay. But what we would do is we would go from the side, right? So we tried to do a transhepatic approach first. So you have a cuff of normal tissue that kind of minimizes the risk of bleeding and seeding because it's like a cuff, like a shield around the target, right? And it's similarly easy to do. Actually, it's easier to do that than that because you don't have to step in and out of the CT room. Here's another example where you have a bunch of subcapsular liver lesions. These are Mets, but still, again, try to avoid going directly through that. That's also an outside ultrasound-guided imaging here. You want to try to get through some tissue first that's not target tissue, if possible. So what about here now? The other confounding factor with this patient here, who has also likely Mets, is that you have ascites. So ascites are on the liver means that you have no tamponating effect of the abdominal wall after the needle is out to minimize the risk of bleeding. However, this has been published, and the publication with 15,000 liver biopsies, however, not for malignant lesions but for benign biopsies, show that there is no increased risk for bleeding if you have ascites on board. Well, this is basically a paper that showed that you can minimize the risk of bleeding, but you don't know the data of the minimization of risk of seeding. So if you're talking about a malignant lesion, it may not be the same thing that you're talking about when you talk about a parenchymal biopsy with ascites on board. Okay, so here that's a lesion with color, obviously. In this case, what we did is we removed the ascites. It's that easy as that, right? So ascites is not something that has to be permanent. You can just take it out in the same session. So by doing so, you are safer and have the target here. This is the pigtail catheter, and then you can do the biopsy with a little bit of liver in between at least. You could have done this here too, but again, try to minimize risk for seeding and bleeding if you have ascites on board. That's the needle in the target. Okay, another trick to get by is what if you don't have any good way to angle, any good way to have a cup of tissue around the target. So this one is a subcapsular target, but you have ribs on both sides. So there's no good way to angle safely into it. What you can do then with ultrasound guidance is this. So yes, you have an oblique approach that gives you a little more leeway in here. But you can go in, rather than going what the trajectory suggesting here, you can go in a little straighter by angulating the trajectory. The target would be here. So you go on purpose, you go next to the target here, and then you angle with a flatter angle into the target. In order to do that, you have two choices. You either rock the transducer with the attached guide, or you disconnect the needle from the guide and go freehand. Okay? Now, this is one nice trick that allows you to go through normal liver first and then angle safely into the target rather than going straight into that. Okay? The downside, of course, is you have to keep in mind again that you're causing some shear forces here at the liver capsule, and there's a subtle potential of ripping through the liver capsule, but that risk is extremely low. The liver is kind of pliable and elastic, so you're not going to cut through tissue as you angle the needle in a flatter trajectory, right? Okay, here's what can happen. You've seen that probably before, that after an RFA that was done outside, of course, it's a target that's nicely ablated, so there's no T2 intensity. T2 intensity in MR, as you may know, is often a sign of tumors, but you can see a lot of T2 hyperintense tumor just next to it. This one here is a liver capsule here, a little bit of ascites around that, so that's an implant on the periphery of the liver, like on the distance capsule of the liver right there. So it's a capsular seed, not a parenchymal tumor, right? And you can see with contrast that it has already obviously enhancing because there's microfeeders through the capsule that kind of supply blood to that target there. Back to the topic with ascites, you try to remove ascites first if you can. This is the publication that we were talking about with the increased or non-increased risk of bleeding with benign biopsies, but if you have targeted biopsies like this one here, you have to do something about it. So what happened in this case, this is an outside needle going through ascites and getting tissue. In this case, it worked, but try not to do that because you can increase the risk for seeding again. So again, try to get rid of the ascites or get as much cuff of tissue around it as you can. Okay, let's talk about a different compartment, that's the retroperitoneum. So yes, if a lesion is that large in the retroperitoneum that it butts the abdominal wall, you can go easily through the anterior abdominal wall and go right through that. but that means that you would go through the peritoneum, which is obviously a different compartment. So you don't want to do that because you may transfect cells from the peritoneum to the peritoneal cavity for no reason. Okay. And putting a patient on his belly or her belly is usually mostly doable. If patients cannot tolerate that, then just put them on the side. It's usually better tolerated for patients who have breathing problems, for example, right, or need access to airways. You do that. That's a picture from a biopsy book that shows you what the needle would go through. So usually people think that the retroperineal muscle groups are pretty safe to go through, and they usually are. However, they do have blood vessels too. So it's not very well seen, but here, for example, or there. And we have had patients who ended up having the need for an IR embolization of the psoas muscles or of the retroperineal muscles because of severe bleeding. So anything is possible. It's mostly the psoas and iliopsoas that have blood vessels. I've never seen embolization needs for retrospinal muscles, for example, but if you can avoid the psoas, avoid it. So let's say through a more flatter approach or something like that if possible. But if not, you just go through that and just have to inform the patient about the risk. Like this case, went right to the psoas and it went fine. Okay, what if you have no good window to avoid organs like the stomach? Well, there is such thing like a transgastric approach, believe it or not, and that's possible. On patients with pancreatic carcinoma, we usually don't do that nowadays. People do it with EUS, right, endoscopically, so they at least avoid transfection of cells to the peritoneal layers right in here. The posterior wall of the stomach is mostly infiltrated, but it's also a peritoneal cavity, so it's a lesser sac. Ideally, you don't want to do that, but with EUS, you do that, right? So with EUS, you go through the lesser sac in these kind of cases and biopsy through the wall of the stomach. So what if the target is not within a plannable plane? So let's say this one is a kidney here, right? And here's a target, right? It's just a subhepatic lesion. What you would have to do is you have to angle either the gantry or the approach or both, right? This is a CT-guided biopsy. You could also do an ultrasound-guided transhepatic biopsy, but in this case, the operator selected a CT-guided posterior approach, which is totally okay. You have to keep in mind, ideally try to not go through the kidney. The kidney is very vascular, right? So you can skim it with the Hawkins needle, for example, or just go with a introducer only in some sections without the inner stylet exposed, so that gives you a blunt tip as well. You can basically scratch along the kidney surface and navigate the needle to the target area. That's usually pretty safely done. And then you have to basically plan the approach across several transverse images. That's the art here. So you have to basically plan the approach with an angulation in the z-axis. So this is what it would look like. Here's a needle in the most superficial layers. A little deeper down, it's right here just past the pleural space, which is like the tricky part to do. And here you're already beyond the critical zone. So the critical zone for these ones here is usually to not go through pleura, because you would again open a different compartment, right? You don't want to cause cell seeding to the pleural space for a retroperitoneal or peritoneal lesion, obviously. And this one is worked out okay. You can inject a little bit of gas sometimes to increase the space around that, but sometimes the gas is unintentional, but it's also usually not harmful. If you do a sagittal reconstruction, it will look like that. So you kind of barely get underneath the pleural space and navigated the needle in a cranial direction into the target. So that worked out okay. How about if you don't have much space to get the needle in there in the pleura? So you have basically 2, 3, or 4 millimeters to navigate the needle here from the chest wall into the pleura without going through lung. So pleural lesions you want to get to ideally without transgressing lung, right? Obviously. So what if you don't have enough space? You can use what we call the hydrodissection technique or salinoma technique. So once even the numbing needle is close by, we usually often use spine needles to numb up the pleura, because it's deeper than the local injection needle. You can inject saline or lidocaine. So if you compare this image here with this image, this little bump here, this bump is lidocaine or saline, which kind of widens the pleural space on your way to accessing the target and gives you a safer pathway to the target. So you just inject saline or lidocaine again. Lidocaine tends to dissipate a little faster than saline, just so you know. So the trick is to inject it fastly. Just don't slowly inject, but inject really a big bolus, like 10 cc or even 20 cc rapidly. It kind of causes a lump. It gives you a little more time to get the introducer in there. I'll do both in tandem technique. So tandem technique means you get closer with the spine needle, and then you follow with the introducer in the same time or in the next shot. And once you're getting close, you're injecting saline to the spine needle, because there's less saline lost and wasted in the introducer. It's a smaller gauge needle. You create the lump, and then you advance the needle in the target or close to the target. That's a pretty safe and well-published technique. My favorite technique that we often use, if we need to, is the bent needle technique or curved needle technique. That's also published a few years ago with 250 cases. And that's a very good technique, but it only works with the side notch biopsy device, obviously. You can imagine if you would use that kind of bending technique with the full core, it's going to break the whole mechanism that keeps the tissue in place and also wouldn't even allow the biopsy device to deploy. So use it only for this technique here. The important thing is to bend it backwards. So don't bend it towards the trough, even though it's a little counterintuitive for the first moment because you're thinking you're wasting tissue here. You're wasting some tissue maybe, but if you bend it the other way around, the moment the device fires, it's going to scrape off all the tissue here. You end up having no tissue at all. Right? So it's important to bend the needle backwards, so to speak. And what's going to happen once you deploy the device, it's going to do two things. It's going to force the bent portion straight. It's also going to move the whole target with you a little bit. So you can see here the anterior contour of the target is going to be moved more anteriorly. So you're going to end up having tissue which is outside your trajectory. That's the key thing. So if you end up having a tricky target which you didn't get in the first place, you can still bend the needle without redirecting the whole introducer. That's important for lung biopsies, for example, or if you have a biopsy target close to a tricky structure. The important thing is if you bend it too much, the distal portion is going to rip through tissue, obviously, and it's going to end up with no target tissue. So the proximal portion is going to be the ones that have tissue, or the other way around. If this is not within the target, only the distal portion will have target tissue. So it takes some practice and a few cases, and you'll see that it obviously can help you in a few situations. Like this one here, where we ended up first doing a few shots that were kind of off. So this trajectory was okay, still no pneumo, that's good. It's a lung biopsy, sorry, of a patient with a posterior portion mass in here, probably the right, was the upper lobe. Here's a fissure. And then the trajectory would be at the periphery of the target, which you can do, but if you want to sample more core tissue, so both is okay, just for the sake of sampling different areas of the target, you can also bend the needle. Then you would have to bend it the way we discussed, and this is one of the few images which we obtained with the needle exposed. You don't need to do that, but for different purposes, reasons we did. In this case, we to nail down basically and verify that the exposed needle is really in the target, we take a shot with the exposed needle, and that shows that it's clearly in the target. And in this case, the target was just a scar. So even though it looks malignant, it may not always be malignant if it looks bad like that, right? And it ended up being also FDG non-avid on the follow-up PET like 6 months ago to make sure we didn't really get a false negative biopsy. So with negative biopsies, obviously you want to follow up on them one way or the other, right, to make sure the biopsy representative tissue. Another fancy technique, it's a device that we also bought 10 years ago, but we're no longer using it because we didn't find it helpful enough. It's this kind of breath hold monitoring device. It comes with some kind of pneumatic pressure sensors that you strap around the patient. And these are connected to an LED string of lights that have like an arm that the patient can see. You have 3 of these devices. They are wirelessly connected. So one is for the operator, let's say somewhere up here. One is for the patient, and one is for the tech or for the operator when they move out of the gantry area. And the idea is to basically tell the patient how deeply to breathe in. So there's a reference point which you can calibrate and tell the patient, breathe into the line here or breathe into the second green light, for example, whatever you want. That should make sure that the patient always maintains the same depth of breath hold. That's the theory, right? In practice, it doesn't always work this way because patients are trying to Valsalva into that point. That kind of completely defeats the purpose, particularly elderly patients who have trouble understanding what you're trying to convey. They don't do what you want, but they do the opposite of what you want with the good intention. So you end up doing sometimes another trick, just remove the LCD display from the patient side. So just tell them breathe in the same way you did last time, and then you are the only one who has a visual feedback on what's going on. That helps you as well. Okay. Another device that we've been using in the past is what we call the navigation device. It's tightly attached to the fusion system that we have. We're not using navigation much because it's a lot of effort. So you have, let's say, a funny lesion in there, and the goal is to basically go in real time without scanning, right? So how do you do that? You have to first register the patient. I'm going to show you in a second on what that means, and you end up with this kind of funny display. We'll do that in a second. So what you need is an RF antenna. That's basically your satellite tower, okay? Let's say you have a cell phone. That's your tower. And this is your antenna. That's your cell phone. One is for the patient. Another one is for the biopsy stylet, the inner stylet. And one is for the ultrasound transducer if you do it with ultrasound guides. So then the system knows where these two devices are. This one goes to the patient chest as an adhesive layer here. This one is for the needle itself, and this is for the system to know where the ultrasound transducer is, so you know what kind of plane you're scanning. Okay, this all gets together into one system, fed in, and it gets different feeds on the patient. And you're trying to register the patient. This is my colleague Eddie Dean from London, who is using this a lot, or has used it a lot in the past. So the RF antenna is, or tower, I should say, is mounted on an articulated arm. Then you have the tracked introducer right in here, and you have the tracked transducer. As you can see, this is just for display purposes. Doesn't wear a mask or a hat. Okay, satellite, the two receivers, and then the ultrasound system is actually on the left side here. Okay, and then you can fuse images, for example. You can fuse the ultrasound image with the CT image. So this is the ultrasound part. Say it's a liver lesion. It's a CT part. This patient had a partial resection, so you have a lot of bowel coming in and obscuring your image. Even though you see the target here, this is for teaching purposes, just so you see what's going on. This patient would not need any navigation because you see the target already with ultrasound alone, right? But what navigation does is it's producing and projecting an image of the virtual needle into the target or along the target, which you have identified on ultrasound or CT before. And you kind of superimpose the CT image on the ultrasound image right here. And then you can navigate the needle, which has a tracker obviously, into the target, regardless if you see the target in real time or not. So if you have an ultrasound guided procedure where you don't see the target, you can still go through what you see with CT. So it's an artificial live CT image superimposed on the ultrasound. Let's go back to the CT only image. I cannot show you this in real time because the movie isn't running, but the idea is we have registered the patient. The system knows where the needle tip is. It knows where the target is because you marked it electronically. And it knows where the patient is because you have a patient tracker mounted on the patient right here. And then the dotted line here would be the projected path, okay, in different orientation. It's a sagittal reformat, that's a coronal, that's an axial. This is all live, so the system does it automatically. And the ring here tells you how far you're away from the target. So you're like, let's say 2 or 3 centimeters away from the target. And as you move the needle in, you're gonna see this kind of crosshair. That's the crosshair where the needle tip is. You're gonna move this crosshair into the target in real time without scanning. So this is all based on the fact that on the assumption that the patient is not moving, right? It's not breathing. So you have to tell the patient, do not breathe, and then you move the needle based on this saved virtual image. It works sometimes, but it doesn't always work. And it's a lot of work to set it all up. It helps you in some instances, and I'll show you a case where it actually helped quite a bit. So the movie is not running. We tried that, but let's move on to the next. We can. Yeah. Here's another example where you do fusion imaging on a patient where you don't see the target on ultrasound. So this is really helpful there. So you superimpose a CT image. It's a CT with contrast. It's a hypovascular lesion here. With the ultrasound image, you know where the falciform ligament is. They're pretty close. This one is falciform ligament in here, right? Segment 4, segment 5. So it's the gallbladder fossa area here. But you just don't see the target, right? It's just isoechoic. In this case, you can either fire blindly, which you don't want to do, or you can try to superimpose a technique, and with a semi-transparent image, some people like this one here. I prefer to just do side-by-side comparison. You basically drive the needle into the CT image while having ultrasound pseudo-guidance, so to speak, right? And this ended up working well. This one here is another example where you have MR evidence that after the ablation zone here, you have some local recurrence right there. You mark this as your target, and then you go in with fusion technique again and try to re-ablate this area in here. This is the ultrasound live image where you don't see anything. In some instances, you see the ablated zone, but you don't see where the residual tumor is, right? So it would be somewhere in here. So this is totally isoechoic, and this is why you would need sometimes fusion to basically use this superimposition technique to get safely to the target. Again, relying, of course, on the fact that you did a good match, as we call it. Match means that the different topographic landmarks match, so the liver contour has to match, and let's say the portal venous bifurcation, these kind of things help you to identify that you have a good match. And then the needle came in here and ablated the target. You're almost done. A few more examples. That's a patient with an outside RFA recurrence, came to us. He's a recurrent tumor. There was a colorectal carcinoma next to the ablation zone right there. It was approved, was confirmed, with FDG avidity. And then with ultrasound and a sagittal approach, you could see the ablation zone here. And we assumed that this one here is the recurrent tumor, but we couldn't really prove it. So what you do then is you can either do the navigation technique, or you can use something more simple, and that is ultrasound contrast, which is the new kit on the block for the US since last year. It's helpful in some cases. So you can see the ablation zone here, not enhancing at all. You see a hypervascular nodule or something which rapidly washes out. That's just after 30, 40 seconds. You see the washout here, and that correlates pretty nicely with this portion on CT and PET. These images are now 90 degrees rotated, so you have a better match and visual confirmation with the ultrasound image which was obtained intercostally. And then before and after the ablation, you can see that the zone here, which was a recurrent tumor, is ablated based on the helpful guidance with the contrast portion of the image here. All right, how about this poor patient? This patient was 36 years old, had some pain, and has this kind of mass in the spleen and also many masses in the liver. You could think that it's not difficult to biopsy that. We biopsied and ended up being all necrotic tissue, so we didn't know exactly what was tissue, what was liver, and what was necrotic target. So in order to identify where target tissue would be, the patient had to come back again. With color ultrasound didn't help you much. You could see a few selected vessels, but you wouldn't know exactly what is target and what is not. And with contrast, you could clearly see that these are all necrotic tumors with a small rim only of tissue that's viable. The echogenic part here is just normally enhancing liver tissue. And based on that fact, it's a side-by-side view, as we call it. So it's an unenhanced B-mode image in the real time. After having a minute of contrast, you see the parenchymal phase, and these are the enhancing portions. You're going to get to those. You can either do it in real time, or you identify the portion and then go through that, and end up being angiosarcoma, and the patient didn't live longer than a month after this biopsy. Okay, for CT purposes, you also need to know that every CT has two lasers. One is inside the gantry here, which is like the laser visiting the imaging slides. And one is actually outside the gantry, out here. This one there is like 25 to 30 centimeters distance from each other, depends on the manufacturer. And that's a laser that you can use to drive a needle safely into the plane without having any z-axis deviation. So for x-axis, you can go left-right, but z-axis here will tell you to stay in plane, and you are in plane once the laser is nicely reflected on the hub. So once it's reflecting here, you know you are totally within the imaging plane, and it kind of avoids deviations in the z-plane. Okay? Here's, for example, another device that we used in the past and no longer. That's the angle assist device. So if it's not perpendicular to the trajectory, if you have to angle off a little bit, you can guesstimate how much, or you can measure that. And this device here helps you to measure that. It has a little dial in here. So this dial here is in 2 degrees increments. It has like a level in there. So the gas bubble you can barely see in here. And once you have leveled off the device, you have dialed in the angle, then you can try to follow this angle by attaching the device to the needle and safely drive it into the predicted angle. And sometimes it works pretty nicely. It's a pretty cheap device. It can help you for in-plane access, but also helps you for out-of-plane access. Let's say this one here, where you have this adrenal gland mass similar to the other patient that we have earlier in the talk. Now you want to know how much to angle into that in order to get safely around the pleura. You do your transverse images and you think it's all easy, but how did you get there, right? So how do you know where to get to the skin? So what you do is you do sagittal recons first. So this is, let's say, one without the needle. You determine what your target plane is. You measure the angle that you want to go through. You dial that angle in, and then you measure the distance that you have to go into from the skin level. So it's about a 10 centimeters difference in order to angle it 45 degrees up. You nowadays do this without the angle assist device. We kind of measure it on the image and measure distance on the skin, and it works the same way. Okay, quickly before we end, one new technique, which is actually very old, is more than 20 years old, but it hasn't been published well. Now there's a new paper out there from this year showing the so-called blood patch technique is safe to minimize the risk for pneumothorax. It means like on your way out with the introducer and lungs, you inject blood, and that's kind of that functions as a plug, and it decreases the pneumothorax rate by 30%, and even decreases the chest drain need by almost 50%. So we use it a lot now whenever we do a lung biopsy. Another thing you want to keep in mind and you want to offer if you cannot do a biopsy is you can wire mark things. So it means that you place a needle in there with a wire. This is a wire from the mammography colleagues from obviously the breast section. It's a hook wire, and you leave it in there, and then the surgeon takes the whole section out if that's what they want. But it has to be orchestrated with surgery, obviously. The patient goes straight to the OR with the wire in there. Nowadays we place gold anchors, so little markers in here rather than a full wire. But some surgeons still want the wire and not the anchor. All right, final case should be this one here, where we kind of pulled all the bells and whistles. It's a young patient with a potential recurrent tumor next to the aorta here. Patient had been already surgerized there, as you can see here, and there's no good way to get to that. That's the aorta. So we chose to take a transsternal approach, drilled a hole here to the sternum. And how do you do that? You need navigation for that because you don't know exactly the angle. So you need to constantly see what the angle is that you need to drill to, like here. And then get a needle in there, show that we kind of were off a little bit, but there's not enough space. So you inject a little of saline in here. So you create a saline pad to be safe and push the lung away. And then you can do the biopsy thing, but things move around during the procedure, and then you had to move the needle into an arched way. So you have to use the curved needle technique again here in order to not fire into the lung. That ended up working pretty nicely, and the patient actually did have some recurrent tumor right there. So here's a list of things that you can look up on the recorded talk. I'm not going to read through all these again because we discussed all that, what to do in what kind of scenarios. So these are some tips and tricks that can help you to get by some problems. So again, make sure you get the indication right, know your tools and devices, know the techniques, have a workflow that helps the patient with, remember, just clean the skin first and then let the lidocaine work while you set up the device and all that. Then make sure you don't do any things that are up for malpractice problems and that kind of stuff. So always work in favor of the patient and check your results. Sometimes if you have negative results, it's up to us to call the clinicians and tell them what we can do better next time, what we cannot do, just so they have some guidance what the next step would be. All right, thank you very much. The UDAP version of famous Samuel Shems saying is not the 14 gauge needle, but the 20 to 18 gauge needle, and a few tricks that we used as discussed. Thanks a lot.
Thank you.